Cukup. Terlalu naik.
Apa? Nggak pagi. Nggak pagi, saya rasanya jam 7, jam berapa? Jam 6, jam 7 tuh rasanya ngecoy, nggak gede.
Pagi dokter Dede. Suaranya kemute kayaknya dok.
Pagi dokter.
Pagi dokter Andi, pagi dokter Dede,
Ada bos. Apa kabar Prof Kiking?
sehat-sehat.
Senang sekali ketemu Prof Kiking nih.
Udah lama nggak ketemu. Dokter Dede itu belum suaranya belum diapa,
Dokter Dede masih mute.
masih mute itu.
Prof Kiking di mana nih? Di Medan.
Di kantor di Medan.
Wis, iya. Sehat tapi ya. Enggak.
Enak dokter Andi tuh, banyak kali tumpukannya,
Apanya? Tumpukan apa? Ya di kantor.
tumpukan tugas.
Itulah. Berkas lama aja dok. Prof. Kapan ke Bandung lagi Prof?
Aman, tambah kurus ya sekarang ya.
Siapa? Saya. Efek kamera kayaknya.
Oh gitu efek kamera ya.
Bikin senang aja. Ini saya kan di rutin Sulu, Prof. Dokter Dede. Jadi sekarang bolak-balik di konsul untuk meningitis TB, jadi belajar lagi, Prof.
Mantap kalau kayak gitu.
Ini soalnya kalau dulu sebabnya OMP,
Oh gitu, Prof.
mastoiditis.
Dok.
Kalau sekarang
Iya.
bagaimana?
Ini meningitis TB kan, dok?
Ini mengenai bakterial
Oh,
meningitis, bukan?
bakterial, bukan TB ya?
Bakterial kok bukan TBC.
Bukan ya, dok?
Bakterial meningitis ini, Prof.
Iya, iya. Siap ikut. Aduh.
Kalau dulu obatnya pakai kloamfenikol 4 gram sehari.
Ada yang baru, dok? Ada
Saya
yang
belakangan
baru.
tuh nggak pernah ketemu meningitis bakterial. Juga udah kurang aktif. Bagaimana di bagian?
Ya di bagian dokter Dede.
Masih banyak tidak? Ada kesan sesudah tahun 2000-an tuh OMP, mastoiditis lebih ditangani, jadi bakterial meningitisnya sangat-sangat menurun.
Jarang, Dokter Dede.
Iya
Satu
betul,
persatu lah.
iya betul dong kalau gitu.
Iya.
Tapi yang tidak kita kuasai itu meningitis TBC,
Iya betul.
bertambah-tambah aja.
Dokter Dede di rumah dok?
Enggak, saya ada di rumah ini,
Iya, mendung ya dok ya? Duh, dingin.
200 meter dari rumah sakit Totin Sulu.
Iya, tetangga sekarang dok.
Enak ya Dokter Dede. Dokter Andi jadi bos di Rotin Sulu deh.
Itu
Bosok, Prof.
rumah sakit sudah dari zaman Belanda. Termasuk sebenarnya bagian dari rumah sakit Totin Sulu itu yang bagian yang sekarang jadi Unpar.
Parahyangan ya, Prof. Dok.
Di sepanjang bukitnya itu ada banyak rumah-rumah kecil tempat orang yang di sanatorium itu ya istirahat di situ. Makanya nama rumah sakitnya itu Solsana. Jadi sehat karena matahari. Waktu itu belum ada obat TBC.
Udah 90
Kita
tahun ya, dok. Kemarin ulang tahun ke 90. Zaman Belanda. Cuman nggak ada bangunan heritage-nya, dok. Bangunannya dirombak tapi nggak ada heritage gitu. Beda sama rumah sakit lain.
ya waktu saya ke sini tuh dulu kalau ke dalam tuh pohon-pohon cemara Norfolk masih banyak. Itu cemara batangnya itu melintang 90 derajat gitu. Seperti di depan gereja yang di Cikapayang. Itu cemara Norfolk namanya. Di dalam banyak dulu.
Ya sekarang sih udah padat, dok.
Ya iya udah
Motor.
zaman dulu ya sebenarnya Bukit Jadian itu
Morning everyone, selamat pagi semuanya. Dokter-dokter yang ada di online, Dokter Dede, juga Dokter Anji, dan dokter lain. Let me introduce Professor Jerry Fadli. He's a professor from Amsterdam UMC, and then a world-renowned expert from the Amsterdam. Professor Van der Beek is well known for his expertise in extensive research and clinical work in bacterial meningitis. Also, his contribution have significantly shaped how we diagnose and manage this condition today. Fun fact, kalau teman-teman buka tentang bacterial meningitis di PubMed, mungkin halaman pertama yang muncul itu nama beliau ya. Your name will be appear as the first recommendation in PubMed. seek some paper in bacterial meningitis. Okay, so I think that's the introduction. Professor, we have like no limit time. You can tell us everything.
Oh, that's dangerous, right? That's
Okay.
dangerous. Yeah.
Oh, yeah, okay.
That's dangerous.
Yeah.
So thank you very much.
Yeah, let's finish.
And I hope everybody online can hear me well. Otherwise, you should tell me. I can arrange it, but they will arrange it probably. So for me, it's an honor to be here. Actually, I'm on holiday. But I always like to see patients abroad or see clinics abroad. And I was planning to go to Indonesia already for a long time. Because every year we go to one Asian country, but I never been to Indonesia before. And long time ago, Dr. Rizal visited Amsterdam. And I always had in mind, if I go to Indonesia, I have to go to Dr. Rizal. and that's what I did. So I'm really glad we had a great day yesterday, so thank you for that. And he arranged everything very well. But still, I'm on holiday, but I'm honored to be here for you to speak about bacterial meningitis. So as you've been told, I work in Amsterdam. So I do neurological infectious disease, but nowadays I also heading the department of virology. So that gives me less research time than previously, but still we do a lot of research. And I will tell you something about that today. Let's see how it works. Page down. Oh, can I go to the next slide? Oh, yeah. So this actually, I work at the University Hospital in Amsterdam, and we recently merged. So we are a big hospital. So we have two buildings, this one and that one. I don't know who you've been in Amsterdam previously. Dr. Rizal's been there, yeah. So some of you've been there. So in the city center of Amsterdam, we have kennel houses. And actually we live in one of these nice houses, which is really fortunate. It's the quality of life is good in Amsterdam, but the food is not. So yesterday I had dinner with Dr. Rizal and the food was great. That's something we don't have. So our department, to give you an impression, I heard you have 60 residents. In neurology, we almost also have 65 residents, and we have like between 50 and 60 staff members, of 50 and 60 neurologists working in the hospital. Thank you. So in our department, like 700 people are working in total, and we all do translational research. So we pick like 6 areas of research. So we do cerebrovascular disease, we do a lot of clinical trials, and that's what we try to do in all these areas. Now we'll show examples on bacterial meningitis, but we have these programs in all of these 6 areas. So what we do, we build up big cohort studies or European or worldwide clinical trials, and then we sample our patients and we bring these samples back to the lab. And then we try to search for new treatments, and then we do new clinical trials again. So that's the philosophy we're doing in Amsterdam. And it works pretty well. So, but today we do a lot of research, also in our neuro ID unit. But today I will focus on community-acquired bacterial meningitis. And I already heard you see few cases of community-acquired bacterial meningitis. But if you see these patients, it's important to realize it's completely different than nosocomial bacterial meningitis. So community bacterial meningitis mainly attracted to the throat, like the pneumococcus, the meningococcus, while nosocomial bacterial meningitis are patients on the neurosurgical wards. Do you have neurosurgery in the hospital? Yes. Yeah, so you see probably lots of patients with nosocomial meningitis, so post-neurosurgery patients or patients with a CSF catheter. But I will not be talking about that. We do research in these areas, but today I focus on community-acquired bacterial meningitis. It's a rare disease, but still in Europe, it occurs about 22,000 times a year. And in our hospital, we see a patient like every 24 hours or so. But of course, we are a bacterial referral center, like your center. It's a bacterial infection, about 70% is caused by the pneumococcus. And meningococcus is really rare nowadays. Both of these bacteria give an asymptomatic compensation of nasopharynx, and we don't know exactly why. It's a very complicated process, but apparently some of these bacteria are able to cross the barrier in the nasopharynx, survive in the bloodstream, and even go into the brain. And we think that happens pretty often, but most of the times you get rid of these bacteria, even when they're in your brain, but sometimes you don't. And if you have a bacterial meningitis, it leads to uncontrolled inflammation. So on the upper side, you see the brains of a patient who died on our clinical ward, pneumococcal meningitis, and below you see the infiltrates around the blood vessels, and that's a hallmark of bacterial meningitis. So most of the complications are due to vascular complications. Next slide. The case fatality of bacterial meningitis is still really high. And we've made improvement, I will show that, over the last 40 years or so, but it's still really high. So this is a figure of a recent paper of ours where we just plotted all the published patients in the world literature. So developed and undeveloped countries, or high income, low income countries, of children and adults. And here you see the case fatality rate over the last 80 years of children and adults. And you can see the progress we made, but still the mortality rate in adults is 15%. And that means in our hospital, we have like lots of patients on the ICU. We have a partly neuro ICU. Still, the case fatality rate is 50%. And about of surviving patients, about half of patients survive with severe neurological sequelae. So it's simply not good enough. The main progress have been made worldwide by the introduction of vaccines. So when I did my medical study, I started in 1992, already old. Haemophilus influenza type B was the most common cause. And in 1992, in Europe, they started to routinely vaccinate, and that was really a success. So in blue, you see the incidence of Haemophilus type B meningitis in the Netherlands. So in the Netherlands, we have a very nice surveillance system. So we know of all patients with bacterial meningitis, the bacterial strain is sent to our laboratory. And that's why we know exactly the incidence, and we can do very nice studies with it. So they have been really successful. So Haemophilus influenza type B meningitis virtually eliminated right now. Then for MenC, Meningococcus serogroup C, it was also very successful. But that goes up and down. It's like a conjuncture, and it already went down before we started to vaccinate. So we're not sure about that. And then nowadays, pneumococcus is the most common cause. We can vaccinate against that bacteria, but what we see There are 92 serotypes. If you take out 15 serotypes, other come back. So there's serotype replacement. So especially it works, but after 5 years, the incidence goes up again, and that's what we saw after the COVID pandemic. We wait for 1 hour, right, to be started. Wait, you wait. Yeah. Okay, next slide. So this is the epidemiology, this is the impact of the routine vaccination with the COVID vaccine. So this is a very important line. This is the median age over the time. So it used to be a disease of children, and nowadays it's a disease of adults. Most common positive pathogen is the pneumococcus. About 73% of all cases nowadays pneumococcal meningitis. And that's important information. If you see a patient, you don't know the positive pathogen. That takes 1 or 2 days to identify, and sometimes 7 days if you have to do it with molecular techniques. Next time. So I would like to present a patient to you. I saw a patient this morning, which I like to see patients. I do a lot of other tasks, but every day I see patients. This is a 30-year-old male who presented with 7 days earache, and then 1 day headache and fever. And that morning he woke up with an altered level of consciousness. On the emergency department, he had a fever of almost 40 degrees Celsius, and my exam was positive for neck stiffness, and he indeed had a decreased level of consciousness. We always scored it on the Glasgow Coma scale. So this patient opened his eyes, localized symmetrically in pain, and was disoriented. Next slide, please. So this is maybe the most important slide of my presentation. So it represents the virtual development of symptoms of a patient. And that also accounts for TB meningitis. And it developed from initial symptoms to death or recovery. What's very important to realize, if a patient with bacterial meningitis presents somewhere on this guideline, we cannot predict how this patient behaves. Even with our database, with thousands of patients, with clinical data, with imaging, with all kinds of genomics, which I will show later, we cannot predict whether a patient deteriorates and dies within hours, or whether you have some time left to do your diagnostics and to do everything. So in a disease as deadly as bacterial meningitis, you should always do your diagnostics and treatments hand in hand. Next slide. Next slide. So what should you do, right? So in our emergency department, if a patient comes in, it takes like 3 minutes to evaluate vital functions, to draw blood cultures, blood tests. The neurology resident or the neurologist who's on the emergency department nowadays assesses the severity and the level of suspicion on bacterial meningitis. And if the doctor cannot rule out bacterial meningitis, we do a lumbar puncture. And a lumbar puncture is really important. So in the American literature, people are sometimes afraid doing a lumbar puncture. Well, we are not. But there are exceptions. I will discuss that later. It confirms your diagnosis. It confirms your positive organism and thereby rationalize your treatment. Next slide. So a lumbar puncture is not dangerous, but it can be, and that's shown on this slide. So on the left side, it's a normal situation. In the middle, you see the situation of a brain infarction. So patients with bacterial meningitis, 1 out of 3 patients develops brain infarction. And this brain infarction causes brain shift. And that's the magic word, brain shift. So it shifts from the left to the right side, And on the left side of the slide is also brain shift, but that is downwards brain shift. This is the situation where there's brain edema with downshift. If you do a lumbar puncture in these two particular situations, so brain shift to one side or brain shift down, you remove the stopper from below, with the risk increasing the brain shift. And then the patient can cone, so vital brain structures like the brain stem can be compressed and your patient dies. It's a rare situation, but it does happen. When I was a resident, I did a lumbar puncture of a child with encephalitis. I did the lumbar puncture, and while I inserted the needle, the patient died. And that's a terrible situation. Next slide, please. So these are examples. So these are patients all with bacterial meningitis. So on the panel A is patient with brain shift due to brain infarction. On B, there is an obstructive hydrocephalus, which also gives, yeah, but not for the people at home, right? But it's on B, it's hydrocephalus. If that's obstructive, that's always give downwards shift if you do a lumbar puncture. Here's a patient with a brain abscess also brain shift. And patients with brain abscesses, they also present like bacterial meningitis. And in D is a patient with generalized brain edema. You could think it's a subacnoid hemorrhage, right? If you see this scan. But it's a pseudo subacnoid hemorrhage because of the downward shift. In these patients, if you do, there's a pointer now for also people at home, right? How can I move it? Oh, there? Okay. So, if you do a lumbar puncture in these four heavy patients, that's dangerous. So how can you select patients to do cranial CT? Because you don't want to do cranial CT in all your patients. Next slide. So there was a study, some studies, we also published some studies about this, but this is the recommendation of the European guidelines we wrote. So when should you do cranial imaging before lumbar puncture? So if you have focal neurologic deficits, but not cranial nerve palsy. So cranial nerve palsy is mainly because of the high pressure, intracranial pressure. And high intracranial pressure, that's no brain shift. So then there is no contraindication for lumbar puncture. But if you have hemiparesis, there is new onset seizures, severely altered mental status, so your patient cannot localize anymore, or has a severely incommunicable state like HIV infection. Okay, next one. So this patient, we did a lumbar puncture, right? And there was a cloudy CSF. These are the fingers of Matthijs Brouwer. He all knows him very well. He's another professor at our department. And this patient has like positive CSF, and there were pneumococci in the gram-stem, gram-positive cocci. Next slide. This patient was easy, right? Sometimes it's not so easy. Sometimes it's a really diagnostic problem, and we also do diagnostic studies. And this was published like 2 days ago from our group. And here, what we did, we have like a cohort study where the patients are entering the study with suspicion of a CNS infection. So in this group, we have like bacterial meningitis, TB meningitis, we have autoimmune encephalitis, but also patients with flu or no meningitis at all, but suspicion of bacterial meningitis. And then we can do all kind of and then we can do all kind of genomics or proteomics and see what's predicting, what's doing better than CSF white cell count, for example. But the most interesting thing is that you can also use easy tests. So in here we tested the diagnostic accuracy of C-reactive protein in CSF. And that's really easy if you have a washing machine. The whole world has washing machines to do the CRP. You can just put the CSF in and have a very good value. And here we use a validation cohort from the Netherlands, 1,000 patients, and then a validation cohort from Denmark in pediatric population. And we did an implementation study in our own hospital where we routinely measure CRP in CSF. And here is the receiver operating curve for differentiating between bacterial meningitis and other disorders. And you can see that it performs excellent and much better than CSF white cell count. So nowadays we do both. We do the CRP and the CSF white cell count. And this might be also very interesting for studying maybe in your population. I read from Rizal you have a very nice cohort here. If you have a cohort of all kind of different patients, you could think of setting up such a study measuring, for example, 100 GP meningitis patients, just checking whether it works in GP. It's cheap, it's easy, you can do it here yourself. Next one. So we treated our patient, and then you don't know the cost and benefit. So you use a table like this, determining the likelihood of a cost advantage. So these are empirical treatments for the rest of the world outside the Netherlands, because in the Netherlands the resistance rate is really low, but outside the Netherlands much higher. So in these patients normally you give vancomycin plus amoxicillin plus a third generation cephalosporin. In the Netherlands we give amoxicillin plus a third generation cephalosporin. Next slide. So most people know me from the adjunctive dexamethasone treatment, and that was my PhD. So for me, that's already a long time ago, but I keep on talking about it. So the rationale of investigating dexamethasone came from animal studies. So in these animal studies, so I will show some data about that later on. We also do a lot of animal work. But you take a rabbit or mouse, and it's really sad, of course, for these animals. But then we give them meningitis. We inject the bacterial in the CSF. We let them get ill, and then we do our research. And that showed that you have lysis of bacteria, otolysis, or neutral antibiotics that gives high levels of pro-inflammatory products, which again give lysis of bacteria, which ends up with all kinds of secondary destructive effects in the brain compartment, but also in the systemic compartment. And we were the first to do a randomized controlled trial, well powered in the European population, in adults, showing that it brings down unfavorable outcome, but also that significantly. And the effect was most severe in the most severely ill group, the pneumococcal meningitis group. Then we did a meta-analysis. That's what you should do. You first do a trial, then you pool all the trials, showing that in high and medium income countries, dexamethasone should be given. And we did an individual patient data meta-analysis, pooling all the trials on an individual level, showing that indeed it has an effect, but we couldn't find effect modification. Okay. Next slide. So then after these results were published, guidelines changed. And then you can do phase 4 studies. So you can see what the actual effect is of the implementation of your new treatment. And you can see all over in in the Western world, you see a decrease of mortality or unfavorable outcome due to the introduction of dexamethasone. Next slide, please. Then this study was published, was a prospective cohort study in the whole France, collecting all the listeria cases. So they collected more than 800 patients with listeriosis, like 250 patients with neurolisteriosis. I don't know whether you see it here, listeriosis, probably not so much, right? But they showed that the patients who were treated with dexamethasone did really badly. So after this study, there was a bit of a hesitation, and then guidelines said, well, you can give it for pneumococcal meningitis, but not for the other forms of bacterial meningitis. Well, I don't think that's true. Next slide. So in our cohort, we have a prospective cohort study where we sample our patients. We now have more than 3,000 patients. We selected the listeria meningitis patients. 60% got early dexamethasone. The fatal outcome was really high, so it's a really severe disease. And if you look at the effect of dexamethasone, it also works in listeria meningitis. So my opinion, and that's also what I write in my review papers, is that if you see a patient with bacterial meningitis, it doesn't matter which positive pathogen it is, you should give dexamethasone. Next slide. So let's get back to our patient. This patient was treated with penicillin only and dexamethasone. He made an excellent recovery. And I still remember this patient because I discharged him earlier than the guidelines. So I stopped treatment 10 days because he was doing fine. He went out of the hospital, and just outside the hospital, in his car, he got sudden headache and went into a coma. Then we treated him with ceftriaxone, metronidazole, and dexamethasone. Next slide. He was transported to the ICU. We did an MRI, and we saw bilateral infarction, and also the brainstem there was an infarction of the brainstem. Next slide. So then the patient died after 21 days, and we did an autopsy showing thrombosis in the posterior circulation, and there was a massive posterior circulation infarction, and that was a new complication. So then we went back to our cohort. Next slide. And then we found out that yes, overall dexamethasone has a good effect, but we introduced a new complication with the dexamethasone treatment. About 2% of our population has a similar picture. So that sometimes they're discharged, they're already home, they suddenly develop headache, and then they go into coma, and they almost all die, and these are the MRIs of the patients. So apparently, overall it works. We're constantly searching for. Next slide. You should realize if you're searching for new treatments, it takes a long time. From the basic research to the patient benefit from dexamethasone, next slide. It took about 40 years. And that's something to remind. Clinical trials are key. You can do them only a few times in your life to do a large clinical trial. So you should pick out the best possible treatment to do a trial. You just finished the high dose rifampin trial, right? I saw the results. It's very important, but of course it's disappointing. So you should realize if you have a new treatment, you should pick the best treatment with the biggest treatment impact, because these trials are really difficult for. Next slide. So for example, we did this trial. moderate hypothermia in severe pneumococcal meningitis. When we started up this trial, there were people saying to us it's unethical. Like in all Scandinavia, they were doing moderate hypothermia in severe comatose patients with bacterial meningitis. We did a clinical trial. There was strong evidence in animals and case series. The trial was stopped early because of a safety problem. And this is the Kaplan-Meier curve. So the controls, there was a death rate of 30%. In the hypothermia, was almost double. So that was really disappointing, but we had an answer. So they stopped cooling these patients in Scandinavia, Belgium, and France. Next slide. But it takes a lot of effort. So now we're searching for new treatments. And I will show some examples. I will go not really in depth because you're mostly clinical doctors, I think. Well, we try to combine the animal research with the clinical research. So, for example, these are high resolution pictures of our animals and humans who died of pneumococcal meningitis. And then you can do very nice research in these samples. So we try to do autopsy in all patients who die in our hospital, especially in those with CNS infection. I don't know whether you can do autopsies in your hospital. Not really? Oh, that's a pity. Because, for example, we use these samples to show which receptors the pneumococcus needs to enter the CNS. And then that's really nice research. And then you can do animal research, randomize your animals between treatment groups, finding out the specific receptors that these bacteria need to enter the brain. But of course, for patients, that's not really helpful because you can block these receptors. But you can, of course, give not these very expensive treatments to all patients with pneumococcal sepsis to prevent pneumococcal meningitis, right? So this is nice research, and it helps you to get into high impact papers, journals, but it doesn't help the patient. Next one. This is also nice research. So what we also do is to infect zebrafish. And we think zebrafish, they're strange, but that's really like the human situation. So we harvest these zebrafish eggs, we decolonize these eggs, and then you have like very small fish, and we inject them in the hindbrain and give them meningitis. And then we can do very nice research with them. And there are a lot of people from abroad who come over to our laboratory to learn this. And I would like to say, if you want to spend some time to do research at our laboratory, we are happy to accommodate. For example, this is a paper published where we showed with dual RNA sequencing, which is of course is really complicated, that pneumolysing, which we know is important in the pneumococcal infection, is crucial. Another study, it's really interesting. I always thought of what makes patients negative. I mean, we always think it's because the infection. Well, we actually don't know. And this study shows why zebrafish are getting negative in bacterial meningitis. So we have like CSF contacting neurons in your spinal column. That it's important for your proprioception, right? And if you get a pneumococcal infection, these cells are the first to react. So they're not the leukocytes, not the complement system. These cells, so these cells who take care of your proprioception, they are the first responders. And we show that if they see pneumococci, they sense pneumococci, they really get crazy. And then these fish get negative. So that's why the patients get negative. Does it help your patients? No. But it's nice research. Next slide. It's okay. So another thing we do, and that finally will help our patients, we do a lot of genomes. And I will not show the results in detail, but of course you can do sequencing of the patients and of the pathogens. And then you can do an interaction analysis. And then you have some hits for susceptibility and for severity. And another important finding of this study was that about 60% of the probability whether you die or not is in your genes. So it's not in, so that whether you are susceptible for meningitis is mainly driven by the bacteria. Whether you die is mainly driven by your own genetic makeup. Next slide. Oh, it's here. Okay, so I will just continue, right? So one of these markers that popped up in these genetic analysis was the complement system. The complement system is actually the second system that goes on in your immune system after your CSF contacting neurons. So it's really old system of innate immunity, and we show that if you have like genetic variation in the complement system, and in particular in the final common pathway, so in complement factor 5, and especially C5a, that really drives whether you survive or you die when you have bacterial meningitis. And what we can do then in our lab, we can make a genetic modification in a mouse. Just knock out the C5a receptor and then see whether the outcome is better. And that was the case. And then we can, next slide, randomize these mice, for example, between treatments. So just wild type mice. So here is our survival curves for mice treated with antibodies against C5a, the toll-like receptor 2 and 4, or only dexamethasone. So if you treat animals only with dexamethasone, the mortality decreases from 30 to 20%, which is similar as our human population. And if you block C5, all mice survive. Next slide. Then of course you have to use larger groups. So we use like these are big experiments where we randomize like 120 mice in one experiment between the different treatments, and the outcomes are blinded. And then you can see if you treat these mice with dexamethasone plus the C5a antibody, you have an improved outcome. So we did this study right before the COVID time. And then COVID hit in. And when the early COVID days, if you see the pathology data of the patients who died of COVID, that really resembles pneumococcal meningitis. Next slide. So we were talking about doing a clinical trial of blocking C5a in bacterial meningitis. And then COVID hit in. And then with this pharmaceutical company, we did 2 trials in COVID. And it worked. So we did first a phase 2 trial and then a phase 3 trial comparing an antibody against C5a with placebo. We randomized more than 350 intubated, very ill patients with COVID. And there was a non-significant effect on mortality, but in the non-stratified analysis, we found a significant effect. And nowadays, this is one of the 2 registered treatments against COVID. It has a drawback, it's really expensive. But we try to set up now a clinical trial in pneumococcal meningitis. Next slide. So I showed you you should treat your patients early. Treatment and diagnostics should go hand in hand. Dexamethasone, at least in the high income and middle income countries, which I think includes Indonesia, dexamethasone should be given with the first dose of antibiotics. Lumbar puncture is essential. And it might be interesting to study COPD in your population. You should do cranial CT, but only in selected patients. And I showed you that if we want to do a new trial in bacterial meningitis, we should aim for C5a. That's what we will do in the near future. Next slide, please. So this is our research team in Amsterdam. I'm really proud of this. Is Matthijs, who now officially heads the neuroinfection group when I moved up to the health department. And these are all the researchers in our group. And I would like to stress all our data are open access. So if you're here in Indonesia and you want to do research with our data, that's fine. We share it with everybody. If you want to come over for a time, that's also fine. We can learn you how to do research. Of course, you're already doing research. I'm not pretending that we do better, but we have financial situation and we have dedicated research time. For us, it's easier perhaps to do research than for you. So if you want to spend some time in Amsterdam, we're happy to accommodate you. Thank you for your attention.
For your here and I would like to ask the audience for any question, maybe also from the Zoom participant.
Thank you for the presentation. Yeah, I wonder about whether you can share to us the interim analysis of the cerebral abscess treatment.
Yeah, so we're participating in a clinical trial comparing long IV treatment to 2 weeks IV treatment with oral treatment for brain abscess. There are no interim analysis results yet. So we randomize now a little bit more than 100 patients, and we need 450 patients. So that also shows. I mean, we're doing it in Australia, in Europe. The United States are thinking of joining us. That illustrates how difficult it is, and you know that, to do a clinical trial. So I don't have the interim results yet.
Because it's in our setting, it is difficult to have patient like 6 weeks
Yeah.
in the hospital. So if it shows so many findings, let's say,
Yeah.
maybe to help us about that.
I had no interim results. I can only say that the patients we randomized in our center, we didn't have any recurrence or reoperation in the oral treatment group. But of course, you should be really careful because it's not powered, it's just an anecdotal thing, right? And that's, yeah, that's no answer from your question. I realize that. So I don't know. There are some countries that are already doing it. For example, in the UK, there are some centers who, for some pathogens, already treat like 1 or 2 weeks IV and then finish up with oral treatment. So if it's really difficult, I mean, it's better just to give oral treatment than no treatment. And I visited Lusaka, so the hospital in Africa, the end of last year. There also giving IV treatment very shortly and then switch to oral treatment because otherwise they only give 1 week of IV treatment and then the patient dies. So then they're already doing it. But I mean, they don't know the outcome. And there are many patients dying.
Thanks. Thank you.
I have a question myself. So you mentioned that you try CFP in the blood or in the system?
In the CSF.
In the CFP. What your suggestion in TBM patient? Is it also will give us something?
I don't know. I don't, it depends on your question. If you want to differentiate bacterial from TB, I think it's not working. If you want to, I mean, here, I think the bulk of your patients are TB patients, right? If you want to compare TB against viral, then I think it might work as well. So, and I think that's the question here, right? That you have the question, has this patient TB, meningitis, or viral, or autoimmune encephalitis? Then it might well work. Because the COP easily goes up.
Yeah, but then do you think CRP is more like acute marker, not the subacute one, because TB meningitis needs.
Yeah, I don't know, but in my, I don't know, you have to go or you can tell, right? So, but I think that it nicely will differentiate TB from viral or autoimmune encephalitis. Because if you have TB meningitis, if you look at the inflammatory profiles, IL-6 is always elevated to some extent. And I think COP, that means COP is also elevated. And I think it will work, but I don't know. You can investigate it.
Yeah.
It's really easy, right? In the Netherlands, it costs €1 per.
Oh, no, not here. We have to pay like 300,000 rupiah. It's mean not euro.
For CRP.
Yes.
Oh, that's expensive.
Yeah, that's expensive.
Now it's really cheap.
Yeah.
20.
20.
20.
Yeah. It might be interesting. So my colleague Matthijs has an EU grant doing diagnostic accuracy studies, and I think if you want to send the CSF to, he is more than willing to do it, to just measure it and give back the results. I mean, that's for us. That's not. I mean, if you have like 200 samples. The shipment is even more expensive than measuring COP, right? For us.
And you use CRP for predicting the diagnosis,
Yeah,
not the outcome.
no, you can also check for the outcome, but then it might be working not that good in TB meningitis. Then you might want to measure something else. And another thing that I didn't discuss about is other antibodies against cytokines. So what we found, we have not published it yet, that in bacterial meningitis we found in like 40% of the patients, other antibodies against cytokines, and mainly against IL-17. And I think that in GB we found it in COVID first, right? We published it in Science that you have like antibodies against cytokines in the interferon-1 pathway, right? And Reinhard Krekel also published about that. And I think you should also search for the autoantibodies against cytokines in TB meningitis. And that's also very easily done. and not expensive. So if you can check it in CSF, if you have the CSF samples, you can screen for these other antibodies. So for example, we developed a Luminix assay. That's really fast, really reliable, and costs about €4 per test or so. And then you can measure like 16 autoantibodies, a whole array of autoantibodies. So that would also be an interesting research collaboration or thing you could do with your co.
Okay, we have a question here from. Not yet. Ada yang mau nanya? Upi kan yang mau nanya? Madira.
Thank you, Professor. I would like to ask, in this study, as the dexamethasone and complement 5 antibody is immediately given with the ratio of meningitis bacterial. Is immediately or we wait for the effect of dexamethasone itself.
Now, I think if you want to give anti-complement treatment, you should do it early. So and you should also give dexamethasone. And I think it works synergistically. So I think it works really well. We haven't treated patients with C5A treatment. So they have an antibody, but it's really expensive. And the company, they put a lot of money in the COVID trials, right? Like hundreds of millions. And then COVID went away. So they have difficult times now, this company. Because they put all their money on the COVID treatment. And now nobody has COVID anymore. At least on the ICU. And but they are also developing a small molecule. So and that's really cheap. So it's much it's better to give a cheap treatment than a very expensive treatment, right? These antibody treatments, it's in the Netherlands cost about 40,000 euros. And that's ridiculous, right? It's really expensive. While if you have like a small molecule, that costs about maybe 100 euros.
Ada lagi yang mau sampaikan? Saran, tapi kesana, no?
Boleh.
Boleh.
Karena sudah makan jadi.
Sudah.
I think Professor for the very clear. I'm going to ask some practical issues because we have several upsets. We have also the bacterial meningitis. And most of the bacterial that is associated with the mastoiditis. My question is, when should we do the mastoiditis in a acute bacterial meningitis? Which one should come the first, or we just go put the antibiotic and we do the operation? Do you have any time consideration?
Yeah, so it's really interesting. We just published a paper about the clinical infectious disease. So we don't know. That's the honest answer. But if you look at the cohort, I think you should operate if there's really a purulent mastoiditis. It should be operated to do source control. If you have like a purulent otitis, you can, for example, first give tubes in the ear. But if you have really formation of an abscess, which in real mastoiditis is always the case, you should get operated. But it really depends on the hospital you're in. For example, in the Netherlands, there are some hospitals, they always operate. And there are some hospitals who never operate. So it's mainly the surgeon who decides apparently whether he or she is willing to come out in the middle of the night to do the operation. But in my opinion, in our hospital, if you have like an abscess formation, it should be operated in masturbate.
The question is when is the right time to operate? If we have bacterial meningitis, the patient actually is seriously ill, and we do the operation, it will be helpful of
If you do it, you have to do it fast. That's my opinion. Do you have to do it in the middle of the night? Well, prefer, yeah. So, but that's also driven by other things. So in our country, the big bottleneck of hospitals are the surgery rooms. So on daytime, there are no nurses on the surgery rooms. Not too much, not too many. So if you want to do acute surgery, you have to do it in the night. It's interesting, right?
Right.
Yeah, because in daytime it's also possible, but then you have to cancel your normal program. And hospitals, I mean, at least in the Netherlands, of course, the neurology department, we see a lot of patients, so we are financially interesting for the board, but the surgeons are more interesting because they earn most money. Surgeries, these surgeries, they bring in the bulk of the money of the hospital.
I thought it's only in Indonesia.
No, it's also so they have a privileged position.
Okay.
But the problem is that there are not enough nurses. Amsterdam is too expensive to live in. Some nurses, they don't get paid so well, so they don't want to come to our hospital.
Professor, there's one question on the Zoom participant, Dr. Kartika Maharani from Jakarta. She asked you about the possible source of bacterial meningitis other than source near the scalp area. So something like systemic infection. Is it possible, such as sepsis, if you're focal causing the bacterial meningitis?
Yeah, so everything is possible. So we in our cohort we have patients with E. coli, meningitis after urinary tract infection, otitis, mastoiditis are the most common distant bronchial infection. But we have like bowel disease, we have all kind of everything is possible. So and that's difficult because then you have a patient who has a decreased level of consciousness. You think there is a delirium going on with a urinary tract infection, but you should always be careful. We really have a low threshold for lumbar puncture in the hospital, and still patients with bacterial meningitis are missed. And these patients are particularly patients with a urinary tract infection with secondary meningitis.
But the thing is, the patient usually on antibiotic, and then how with the dexamethasone administration?
Also, so we have a general rule, which is not based on evidence, that we in the European guidelines we advise if you have a 4-hour delay, you can still give it. After 4 hours, we don't give it anymore for IV treatment. But if a patient uses oral antibiotics, I just give it. And I'm rather trigger happy with dexamethasone. Maybe because I did these studies, but also because the effect is so. I mean, it halves your mortality with pneumococcal meningitis.
So if the patient hospitalized and then on the IV antibiotic, then we
You don't do it if they are already on 4 hours IV antibiotics with CSF penetration.
4 weeks.
Yeah, but not optimal CSF penetrate, but some drugs really penetrate badly, right? But if you use for example, cyclophosphamide, which is an oral treatment, or can be an oral treatment, that penetrates very well with CSF. Then after 4 hours, we don't give dexamethasone.
And then we also have one question here from Hiking from Medan. He asks, what role does comparative genomics play in identifying genetic differences between highly invasive and less virulent strains of bacterial causing meningitis?
That's a difficult question to answer. We do serotyping of all our strains, and we do genomics of also. We do a whole genome sequencing of all our pathogens, but that takes a while. So we don't have the data about the bacteria when we're treating the patient, so it has no effect. It's mainly for research that it's so interesting. And what you see, especially during the COVID pandemic, we saw a really decrease of bacterial meningitis, except for the stereo meningitis, because these are the respiratory pathogens were almost away because of the COVID measurements. But afterwards, we see a rather large increase of incidence. And that's mainly driven by the highly virulent bacteria. So apparently, during COVID, it all went away. And then afterwards, when it started again, the highly virulent pathogens really went crazy. We had a high incidence of twice as before. And now it goes down again. Now it starts to come in equilibrium.
Yeah, I hope Prof. Keating satisfied with the answer. And then we have third question. It is from Dr. Abdul from Sulawesi. Manado. It's another island.
It's nice to see that so many people
Yeah.
from the whole Indonesia, it's such a big country.
Yeah, you have a lot of fans.
Yeah.
So, Dr. Abdul asks, what is your experience in steroid-related thrombosis while treating bacterial meningitis?
Yeah. So it occurs in about 2%. And what we do, we put these patients on high dose steroids again for a longer time, for about 1 week, and then we taper, and then we get big better results. So in France, they have like a ICU trial network. They aim to trial 4 versus 7 days dexamethasone. So with the thought that we give it only for 4 days based on these animal experiences, and we should give it longer to prevent more cases of delayed cerebral thrombosis. That's a difficult trial because you need lots of patients to prove that. But it's a interesting thought that because before dexamethasone we saw these cases but on day 1, and now we see them later. So that implies that it's just a rebound effect, that we have to treat our patients longer with steroids. But we don't know.
And how about a patient like yours? Just now, you mentioned that the patient getting better, but then suddenly he come with
Unconscious.
unconscious. Is there any place for us to give dexamethasone at that time?
Yeah, we give dexamethasone high dose for 7 days, and then we taper it very slowly. And some have even given cyclophosphamide, for example. But I mean, it's difficult because 70% of these patients will die, whatever you do. So we don't know. But I mean, it's really terrible that you have a deadly disease, right? Then you recover completely because all these patients will completely recover. Then you go home to your family, and then you die after 30 days. It's terrible. Also, this patient had two small kids.
Do you see some pattern of the genetic variation in patient in Netherlands?
Yeah, so patients, 2%, so we cannot get CSF of the diagnostic lumbar puncture. And the only thing we could find in those patients with the late cerebral thrombosis combined with the rest is very high levels of C5a, extremely high levels. So apparently you have this genetic background with a trigger happy complement system that really goes up. And that's actually also if you measure complement 3 months, we didn't publish that yet, but if you measure the complement system, complement activation 3 months after disease, there is a subgroup of patients with so normally your complement goes up very fastly and then goes down gradually. After 2 weeks, it's almost at basic levels. But there is a subgroup who stays very high, who has a tick over of complement, which is really strong. We see the same at COVID. So there were COVID patients, also the post-COVID patients. I mean, I don't like that because it's a terrible area of research. But there is a subgroup of patients with cognitive defects after COVID who has a very high tick over of C5a still. And I think that's a genetic subgroup that is very likely to develop the late cerebral thrombosis. It's really pro-inflammatory. But I cannot prove it.
Yeah. Okay. Yeah. Thank you. Is there anyone?
Thank you for the opportunity. I have 3 questions. So the first question is, I'm wondering about the dexamethasone, because you mentioned that we it's better to not giving dexamethasone if we have already given IV antibiotics with good administration for our. And next to me, Dr. Kartika asked the same question. Could you please explain what is the
rationale.
the rationale for yeah.
So yeah, that's a good question and not so good answer, but I will tell you honestly, right? So there were animal studies done with dexamethasone, bacterial meningitis, showing different time points. So they evaluated time point 0, right? When you give them together with it, time point 4 hours, time point 24 hours. And then they looked at cytokine measurements. Well, not even outcome, but cytokine measurements. At 0, dexamethasone had an effect on the cytokine profile in animals, in mice. At 4 hours as well, right? At 24 hours, there was a bit of difference, but not so much. And then there is you have like a European consensus group. Then you sit together with all these experts, and then you say, well, we have to say something about this. And then in these experts group, with the glioblastoma, right? So if there is a tumor with lots of edema causing complaints, you think, oh, this patient can talk again if I give some steroids, you give steroids. And then you taper it because, well, you don't want to stop it immediately after 4 days because then the mass lesion is still there.
Okay,
Yeah. But I think it was formulated too strongly. Now, everybody in the world will give dexamethasone to patients with brain abscess. And I think the consensus committee didn't realize that when they were sitting together and wrote that down.
So it's still better to taper it slowly, not
Yeah,
immediately.
I think so, yeah. And you don't have to give it to all your patients. I mean, if they're not bothered by it or there's no impeding brain herniation, which is rare in brain abscess. I don't know what your experience is with patients with brain abscess. And if there really is impeding herniation, you should get a neurosurgeon.
Okay, Prof, I think all questions have answered. So now I think
Oh, that's nice. Yeah.
shifting a bit closer. Thank you very much. So now we're shifting a bit closer to home. I would like to take this opportunity to introduce or a bit tell a lot of audience here about what we've done so far in Bandung. So since 2019, Prof, our team has been conducting a long-term cohort of brain infection, and this is our short story about our cohort. So to start, since 2019, our team in Bandung has been actively collecting prospectively data on adult patients 18 years or older and with suspected central nervous system infection. These include cases suspected with meningitis, encephalitis, myelitis, and also brain abscess, all based on the clinical judgment of the attending physician. And we've systematically collected the clinical data and also starting from the clinical sign and symptom, blood test, and also CSF analysis. And we also do neuroimaging, mostly CT scan. And with some patients, we also do a brain MRI. It's a routine part of our diagnostic process. And we also conducted follow-up until 2 years after discharge from the hospital, primarily through telephone interview for participants who couldn't be reached via telephone. We sometimes go for home visit. And then in cases of death, verbal autopsy was conducted to gather information on the circumstances and possible causes. So, especially for HIV positive patient in particular, we expanded the workup to include VDRL, toxoplasma serology, cryptococcal LFA, and also Indian ink staining. We also perform anti-NMDR testing in some subset of patients because it is very expensive and not covered by the insurance. And lung tests we also do in some patients with HIV positive. And in addition to all patients, we also collected a paired sample, blood and also CSF for archiving for long-term analysis in the future. So in this chart, we want to show you the rate of patient enrollment per month. On average, we included around 22 patients of brain infection. So during certain periods, especially at the height of COVID-19 pandemic, we experienced months with no enrollment at all. But however, during peak periods, we sometimes manage to enroll nearly 50 patients with CNS infection in a single month. So here this flowchart illustrates the overall distribution and workup of patients included in our cohort. We screened around 1,608 patients with suspected CNS infection. Out of those, 1,379 cases were confirmed as CNS infection, while 229 patients excluded after clinical evaluation. Next, we stratified the patient according to the HIV status. We see that almost 30 patients were HIV positive, and among the HIV positive group, we managed to do the lumbar puncture to around more than half of the patient, 55.5%, and almost 3/4 of the patient also have brain imaging, and only around 8% of the patient unsuccessfully followed up until 6 months. So the rate of follow-up is almost 100%. There's a higher number in HIV negative, except for the follow-up. So the median age of our cohort was 37 years old, but patients with HIV were generally younger, 33 years compared to 39 years in HIV negative group. This table summarizes the etiological distribution of CNS infection in our cohort of 1,608 patients. We see that the most common cause of overall infection is TB meningitis. 54%. 59 among HIV negative, and lower in among HIV positive is only 40%. In HIV positive patient, cryptococcal meningitis and crypto and cerebral toxoplasmosis and tuberculoma were more frequent, reflecting the burden of opportunistic infection among this group. Meanwhile, viral encephalitis, brain abscess, and bacterial meningitis is more predominant in HIV negative group. And here we want to show you the Kaplan-Meier 6-month survival in HIV negative patient by CNS infection type. We can see here TB meningitis, the blue line, had the worst survival with nearly 50% of mortality by day 60. And also other severe infection, we can see brain abscess and cryptococcal meningitis. We also found cryptococcal meningitis among HIV negative group, but it's only a few. And then on the other hand, condition like viral encephalitis, tuberculoma, and NMDR encephalitis had much better outcomes. And for the HIV positive patient, we see that the cryptococcal meningitis and tuberculous meningitis, the gold and the blue line still have the lowest survival, especially within the first 60 days. Meanwhile, conditions like tuberculoma and viral encephalitis had much better outcomes with survival above 75%. In this graph, I want to show you the functional outcomes using the modified Rankin scale. At discharge and 6 months in HIV negative, and later I will show you the HIV positive groups. The green shades means a better outcome, and the red shades mean worse, and the dark red indicates death. We can see improvement over time in most diagnoses. For example, the tuberculous meningitis. There's a shift from higher disability and death at discharge to more favorable scores at 6 months. However, conditions like brain abscess, tuberculoma, and SLL-related meningitis still show substantial long-term disability. And this is among HIV positive patient. We also see that cerebral toxoplasmosis and cryptococcal meningitis and also TB meningitis still had high mortality and also disability rates even after 6 months. In contrast, neurosyphilis and encephalitis viral showed much better recovery. This reflects the burden of opportunistic excessive infection in HIV positive individuals. So this is all our cohort, short cohort, and this is our team. We've worked closely together along with our colleagues in Jakarta. Actually, the cohort also done in Cipto Mangunkusumo Hospital, but this is special data from Bandung. We are supported by a very solid team, the analyst, data manager, laboratory staff, and pharmacology, social worker, and also clinicians. And we've been meeting regularly, weekly meeting, even when I away from Indonesia, we always see online. Thank you very much. Ada pertanyaan kalau dari Bandung mau udah ini ya lah. Yeah.
Okay, now,
Yeah, sure.
so it's an excellent study, right? It's a beautiful overview, and also that you have such a high rate of long-term follow-up.
Yes.
It's really
Yeah.
exceptional.
Yeah.
I've not seen that in any other CNS infection study, so congratulations about that. So my question is, what did you sample, and did you store the samples for further analysis?
Yeah. So we collected CSF and blood samples. We want to evaluate for like metabolomy and genetic and epigenetic. Also, we collected PAX-gene sample, for example, for RNA, and we also do a microbiological work, and also for the pathogen evaluation. So we plan to evaluate for our patient who didn't confirm the bacteriological confirm. We want to do the NGS. We want to know if the patient actually have some kind of viral or autoimmune causes, because the TB meningitis itself, it's only 35% of positivity. So we still have a big dot CNS infection patient.
And did you also sample the normal patient, the normal neurosyphilis patient?
Yeah.
Because that's an important control group.
Yeah. Yeah, the thing is when the patient come to our hospital and then we suspected the patient as CNS infection, some eventually end up with no infection, no CNS infection, but we still collect the sample. So from
because not all had culture positive.
Yes. So we basically use clinical judgment. We use the Murray score, if you're familiar with that. It's actually not for static, not for daily service, but we use it anyway to identify whether the patient have probable or possible TB meningitis, for example. But if we cannot see any other alternative pathogen, and also the Murray score is not fulfilled for the meningitis diagnosis, so we assume that this patient has no CNS infection.
But did one person decide that, or two independent persons decide?
We usually do the clinical meeting.
Okay.
So when the patient admit to the hospital, our resident usually evaluate the patient, and then we have weekly meeting. We call it infection clinical meeting, and then we discuss about that, and then we agree on the on the possible diagnosis of the patient.
So, but if you really want to do metabolomic genomics, etc., the categorization of your groups is so crucial.
Yes.
Because if you have like 10 patients with TB meningitis that shift from one group to another group, it really screws up your results.
Indeed.
So you might think of getting like a panel
Yes.
reviewing all the data
Yes.
and then see whether there's disagreement
Yes.
and then discuss the disagreement because these metabolomic genomics is really expensive.
Yes.
And making new groups, the basic things is so crucial. Otherwise, you can do lots of metabolomics,
Yeah.
put lots of money in there
Yeah.
because it's all really expensive.
So far, Prof, we only do metabolomic for patients with definite TBM and also the probable.
Yeah.
The probable means that the patient have a cell more than 5, glucose less than 0.5. And why is that we use that categorization? Because we analyze from our cohort since 2006 when Dr. Rizal finishing his PhD. And then we identify that the most predictive variable for bacteriological confirmation test is cell and glucose.
Okay.
So we use only probable and definite cases for metabolomic.
And it's really impressive.
Thank you. Actually, we also have ongoing recruitment, but the cohort itself is stopped at March this year because of the grant is finished. So we have to be rational because it's expensive. We collected the samples and then checked for the microbiological work in our special team. So it's not belong to our hospital because the hospital usually give us a negative result all the time. So we have friends in the microbiology team. They really well trained. So they develop their own demanding optimization of laboratorium. So we usually send our sample to that team, and then we have better positivity rate.
Yeah.
Yeah.
Interesting.
Yeah, I don't know. Maybe in a hospital, usually because this is hospital where resident also learn something, and maybe because of the change all the time, the expert, the lab technician, so the result is not very good.
No,
Yeah,
that's another problem.
but since we have a gene expert, the positivity is actually increased. Oke, ada pertanyaan lagi? Kalau tidak, mana dong? Mana? Oh iya. Enggak ada, alhamdulillah. Okay, do you have some closing remarks or closing statement for our beloved president?
Well, what an honor for me to be here, and I would like to thank Dr. Rizal for having me here. So thank you, Rizal.
Yes.
Raising everything so kind. And I will repeat my statement. So if you want to be in contact, just send me an email. I always read my emails. I always respond. And we are happy to collaborate to accommodate residents or students. And thank you for having me.
Thank you. But we don't have so many bacterial meningitis. I don't know.
No,
It's only one patient a year.
yeah,
Yeah,
yeah, that's not too many now.
Yeah.
But maybe there are more, right?
yeah.
You guys know.
I think our guess is because we are the highest referral hospital.
Yeah, that might be, yeah.
So
Yeah.
maybe the patient already,
Are treated or die.
died.
Yeah. But we do more than only bacterial meningitis, right? So you must see a lot of nosocomial meningitis as well, or not?
Nosocomial.
After neurosurgery.
Yeah, sometimes we consulted from the neurosurgery department
Yeah.
after the operation, and then the patient become worse.
Mm.
But that not so many. Is that our neurosurgeon as good as that?
Maybe, yeah.
Maybe.
But then-
Sometimes they just treat them
Yeah.
by themselves.
Oh, yeah, maybe not some something to our department.
And we also do a lot of diagnostic studies, so that's something we could find each other. So you're planning to do metabolomics and lipidomics. That's what we've been doing the last 10 years. So we have a lot of experience in cell sequencing of these patients. And so if we can help out with that, we're happy to do that. Because the generating data is not so difficult. The analysis is sometimes difficult.
So myself and Dr. Rizal is basically in the kitchen for all the sophisticated tests. So we do clinical things here in Bangladesh, and we usually get help from others.
Yeah, but I mean the clinical part is crucial, right? Your clinical part should be the first part. It's the most important part. Otherwise, you cannot do studies. And so you should not underestimate the importance of the clinical part. I mean, our group, the main bulk of work is in the clinical part, seeing patients, including patients in studies, sampling patients. That's 80% of the work. And the rest, I mean, it's all about techniques and analysis.
But we learn a lot from
Yes.
this format. It's also increasing our knowledge how to give our service.
Yeah, it's crucial. Also, the patient we saw this morning.
Yeah,
I mean, if you check all the data here, I mean, then you almost certainly know the diagnosis. I mean, the clinical questions you get this morning, you can investigate and write papers from this database. You can search how many patients already had an episode previously. And that's probably only autoimmune encephalitis. So it's really important. It's the basis of research.
ada lagi yang penasaran? Ada di sini.
I think maybe one last question about if we have patients with maybe the intravenous dose of the antibiotics. Is it better to give oral antibiotics after that, or just like?
Depends on how long you're treating with IV. If you just have a normal IV schedule, normally it's enough, right? So there are studies in Africa treating like 5 days. So I think we're really over treating patients in Europe with 40 days of antibiotics, for example. There is an exception that may be bacterial meningitis, but that's not really common. Right, so if you see a patient with bacterial meningitis, and if they go well, I would comfortably discharge them after 5 days.
And not actually by oral.
Yeah, or not.
But it's it's interesting that you still give amoxicillin. Is
Yeah.
it intravenous amoxicillin?
Yeah, so in the Netherlands, we recently switched to amoxicillin plus third generation cephalosporin because well, antibiotic resistance rate is really low, but still it's like 2%. So we get third generation cephalosporin against cocci and cocci, and then we give amoxicillin against bacteria. And well, like most of the times, after 2 days, we switch to penicillin. Still.
Recording in progress.
Or we continue with third generation cephalosporin or amoxicillin, depending on antibiotic sensitivity.
And if we don't know the pathogen,
Yeah, then we stop the amoxicillin after 3 days because then we think it's not very likely that the patient has disturbance. Except when there are some risks, for example, if you have a all patient with chronic lymphatic leukemia, for example, then otherwise it was that after 10 days the patients well so early. I mean these guidelines are important, but they're not written in stone. Just guidelines depending on yes, very great. That's a lot of stuff. And I can show it to my group in Amsterdam.
mungkin untuk banyak sudah hadir di acara lecture teman-teman ini kan ada yang kita saya Assalamualaikum.
Ya,
I know it very well.
Semua untuk acara expert lecture hari ini sudah selesai. Izin di end. Terima kasih.
Yeah,